So I'm Joanne Chiwaula, and I'm a nurse midwife. And for those of you who don't know, Malawi is a small country in sub-Saharan Africa. It has a population of 18 million and it's about the size of Pennsylvania. It's one of 62 countries on the continent. And I think it's important to review the development indicators just to get a sense of where we're coming from and where we're really doing this work. So you can see the top line comparing US, Mexico, Zambia, which borders Malawi, life expectancy for men and women, and then maternal deaths and child mortality in Malawi remain among the highest in the world. Although there have been incredible improvements over the last couple of decades, it's still very, very high. And then the next number is a ranking of development overall. It takes into consideration life expectancy, per capita income, and education. And Malawi is around the bottom, 172 out of 189 countries. So there's a huge gap to make up here. You know, looking at the US at number 15, not the greatest where we would hope to be, but Malawi is far, far below. So the next two numbers I look at as kind of drivers of development. So when we think about how Malawi would make up that gap, moving up from 172, you know, they would need a workforce that has a lot of people in middle age, so they are well equipped to take care of the young and the old. And in the US, we have that, but in Malawi, half the population is younger than 18. And then you also need a skilled workforce. So in Malawi, less than 18% of the workforce is skilled. And then the next two numbers give us an idea about healthcare access and quality of care. So we know that in the US, you know, more money isn't necessarily better care, but certainly at the opposite end of the spectrum from Malawi. And then in Malawi, for the population of 18 million, they have just over 600 physicians. Whereas in the US, for a similar size population of 18 million, we would have over 47,000 physicians. So huge difference. And when I was in Malawi, I was there from 2005 until 2008, and I was working at Bottom Hospital, which was a district hospital. In that hospital, they attended 1,000 deliveries a month, and there were 2 physicians assigned to that hospital. And I would like to say that the labor ward was actually just one room with 14 beds. And just as a point of comparison, right now I'm working at St. David's Medical Center, and there they have 280 births a month, and there's 21 physicians who work there to attend those deliveries. So again, you know, I think it's easy sometimes to come in from the outside and look at problems and say, okay, we need to improve this, but I just want you to get a sense of the magnitude of the issues that we're talking about. So I wanted to share the story of Irene. Irene was a young woman who I met on her 3rd admission to the labor ward. She came in and delivered a healthy baby girl and was discharged home, went back to her village, which was about an hour away. And then she bled profusely and came back and was stabilized and sent home again. And then I met her on her 3rd admission after she had bled again at home. So that day, I remember Irene came in supported by family members. She could not walk. She was completely incoherent. She was babbling, but not at all lucid. And she was assisted to lie on one of the labor beds. One thing I learned in Malawi, a quick way to assess for hemoglobin is to check the inner eyelid and to check the tongue and the gums. And Irene, this young African woman, I think she was 20 at that time, had a completely white tongue and white gums and white eyelids. So it was clear that she needed a transfusion quickly, but we still needed to get a blood sample to find out her blood type and also to check her hemoglobin. So a normal hemoglobin, for those of you who are not medical, is between 12 and 15 for a woman. It can drop to 10 in pregnancy and sometimes around 9 after delivery. But usually if it gets much below that in the US, a woman would become symptomatic and we would offer a transfusion. So in Malawi, it was not uncommon to see women starting labor with a hemoglobin between 4 and 6. And this must have been the case for Irene, because if her body had not been coping with chronic anemia, there was no way that she could have survived with such a significant blood loss. When we got her labs back, her blood type was O positive and her hemoglobin was 1.7. So I was on the ward with my friend Deb, who was an American obstetrician who was visiting, and we were extra hands. So we decided to take it upon ourselves to go and find blood. And Deb was also concerned about some other women in postpartum who needed blood. There was no blood in the hospital there. And so we drove about 3 miles to the regional hospital and made our way to the lab. And we got there, met the lab tech. He showed us the refrigerator where there was just a handful of pints of blood. There was a few of A, so he gave that to Deb, and Deb went back to Bottom Hospital, and there was just 1 pint of O positive blood. So he and I were looking at this pint, and he did not want to give me the blood. He said, if I give you this blood, this woman is going to die. Like she needs more blood than just 1 pint. This is not going to do very much. But if you leave this blood, I can divide this into several batches and I can save the lives of several children. And there's a lot of children coming in with anemia because of malaria. So we discussed, and I have O positive blood. So I convinced him to take my blood and give me the pint. So we did that, and I made it back and gave it to Irene, and she got that. And over the next several days, she got a few more transfusions and she survived. And it was incredible. It felt miraculous. And Deb and I, we checked on her multiple times a day. We got to know her family, and it felt really just wonderful to see her leave the hospital with her baby. And we promised that we would come and visit. So about a week later, we came and visited, and it was great. Irene was active and looked great. She could not find the iron pills that she was given on discharge, so it's clear that she wasn't taking them. But her baby looked good, peed through my dress, and I watched her breastfeed, and I saw milk in the baby's mouth. Irene did mention that her baby, she didn't feel like her milk was enough, but watching her breastfeed, I thought, okay, things are going okay. And we left, of course, not before they filled our trunk with vegetables and pumpkins and a couple live chickens in the back of our car. But a few days after that, I got a call from Irene's dad, and he said the baby was crying too much in the night and the baby had died. So I realized at that time, in focusing on Irene, like clearly she was so critically ill, we wanted to save her life. We wanted to make sure that she survived. And we worked really hard to just follow up and make sure she got the blood that she needed. We completely missed how her illness impacted her baby, and really how it impacted her milk supply. And that was one of the first lessons for me about how interconnected maternal and child health really are, and that you can't really look at the baby's health in isolation. You have to consider the mother's health as well. So Deb and I went back and we attended the funeral. And in Malawi, funerals are really a community event. So, it's everyone is out of their houses, sitting around. There's a hush over everything. And babies' funerals are really the work and the care of the women. So the men were all there supporting. They walked us to a certain point, and then the women carried the casket to a grove of trees and had dug the hole and placed the casket and covered it. And it was awful. I'm sure there were other women there who had lost children, and Irene, was beside herself with grief. And I just want to emphasize, I think that it's easy when we are standing from the outside and looking in and looking at those numbers of high mortality to think that people who deal with death are used to death, but it is not possible to get used to that kind of grief when losing a beloved child. So I wanted to also just share a little bit about the interconnectedness of all of these issues. So when there's a child death in Malawi, we can look at the main causes for that death. and people can work on preventing all of these issues. I would add to that, a mother's death would also result, or many times results in a child's death. And we can look at as well the issues that lead to a mother's death and preventing those. If in Irene's case, if she had died, we would say, okay, it was postpartum hemorrhage. Well, maybe she didn't get the adequate care she came in for the first time, or maybe she delayed in actually seeking that care. But we look at, well, why did she delay, to get care? Well, there was no emergency transport. The roads are unpaved and poor. There's not enough physicians who met her there. There was no blood in that hospital at all. And then thinking about her chronic anemia, well, maybe if she had normal hemoglobin, she wouldn't have, she'd had more reserve, then she wouldn't have gotten so low. But, why was she malnourished? Well, her diet and the poor soil quality and everything just layers upon each other. So it is very complex. And I think anytime that we're going in, kind of having an awareness and respect for the larger overarching issue of poverty. And there are poverty alleviation strategies. That's a more common that organizations are putting resources towards that. There's not a lot of data and research showing that they are effective, but still really important to work at that. But I would say at the same time, we clearly need to continue caring for the moms and the babies who are currently being affected. So towards the end of my time in Malawi, I set up African Mothers Health Initiative, as well as Joyful Motherhood, which is the sister nonprofit, which actually implements the work in Malawi. And what we do is support the provision of home-based nursing care for high-risk infants. So we send nurses out into the communities to visit these families and support them monthly up to 2 years. And these infants, we don't have enough resources to do this for everyone. So we're really looking at babies who have significantly higher risk of dying than their peers. So these are orphans, twins, and triplets, babies of moms who are critically ill, and babies of moms who can't produce breast milk. We also support women like Irene who've had near miss deliveries. So whether that means, a significant hemorrhage or seizures from hypertensive disorders or significant infections that led to removal of her uterus, those are the women that we visit. And we provide 6 visits for them, plus a stipend for an income generating project on discharge. And I'll talk a little bit more about our collaboration with Rikapo in a little bit as one of those projects. So this is the sign in front of the office in Malawi. Chimwemwe Mubereki is the name in Chichewa, the Joyful Motherhood. And our goal, this issue that we're dealing with, these infants that have significantly higher mortality rate, I would say this problem is not unique to Malawi. I would imagine that this is throughout Africa and probably much of the developing world. We're only working at the moment in one district, although occasionally we go into other districts to follow a baby, but really covering one district. So we'd like to create a model to really address these issues of infant mortality and maternal morbidity that might be replicated in other places. So I'm gonna share a bunch of pictures. We had a photographer follow our nurses for a couple of days, and I'm going to show you pictures of our beneficiaries and their communities. And I'd like to just preface by saying some of these pictures are people living in very deep poverty. First of all, this is not representative of all of Malawi. This is representative of the women and the communities that we serve. But I also am very sensitive to showing these because they look so different than for those of us who live in the States of what we're used to. And I think it's very easy to, think that, well, these people are used to living in these circumstances, they're more capable, and therefore there's less of an urgency to change. And while, yes, they are more capable, certainly than I am, if you set me down in a similar circumstance, this is not the quality of life that they aspire to, and it is definitely worth the effort to change. So before I show you the pictures, I'd just like to ask everyone to think of a child that you love dearly and the pregnancy and the early childhood period of that child. Maybe your own baby or, a grandbaby or the baby of a close friend. And just Think of what you would do for that child and what you would sacrifice. And then, think of yourselves in the situation. And those are who our beneficiaries are. There are people who love these children incredibly deeply and are willing to do so much for them. So these women here in this picture are four of the beneficiaries. They're each caring for an orphaned baby, maybe a grandbaby, a niece or nephew, or the baby of a deceased friend. And these women, their faces are the faces of strength and resilience and love. And they are really our inspiration from the work that we do and the situations that they overcome and what they do day and night to make sure that these babies survive, give us the strength to go on and to support them because they are doing the bigger part of the job. These people are the change makers. This is our vehicle that goes out 5 days a week. We'll be needing a new vehicle soon. And these are a few of the houses with a mango tree in front. This is the home of someone who is caring for an orphan baby. This is a field that someone depends on for their livelihood, perhaps farming tobacco, I imagine here. This is Eliza. She is one of our nurses and she's visiting this grandmother whose daughter died after hemorrhaging. So her daughter did go to the hospital and was treated and came home and died at home and left her daughter. So we had, let's say between 48 and 80% of orphan infants in sub-Saharan Africa die. So this data came from several studies that were done in the region, one in Tanzania, Ethiopia, and South Africa. There's not a lot of research looking at these subgroups of babies, but this is incredibly dramatic when you think about this group of infants. We had a recent focus group, and I want to read a couple quotes from some of our beneficiaries. So these are women who were discharged and their children were at least 2 years of age when they were at this meeting, at this focus group. I joined the program in 2018 because of this child. The mother passed away when the child was 3 months old. She was born very premature and we didn't expect her to live up to now. I went looking for help, and when I got to the hospital, they told me to come to Wyla Hospital where I would get help. I came here and they welcomed me and helped me well. They examined the child, gave me some clothes, and I went back home. I noticed things were improving in the child. In the past, I used to try to buy milk on my own. They would come home and bring cans of milk. Each time they could bring 8 or 9 cans until this child started eating porridge. Then they stopped giving milk and started bringing porridge. Up to now, if it was not for this organization, this child would not be here. I could not have managed on my own. I do not work. I'm not married. I'm thankful to God that He allowed this organization to be here and to help poor and orphan children. The mortality of twins and triplets in sub-Saharan Africa is 2 to 5 times than that of their peers. So that means 10 to 25% of twins and triplets will die. And I have also another little quote from the mom of triplets. My concern on what happened was my inability to care for 3 children. The way my home is, I could not have managed. They were triplets. I could not have managed. They started bringing me soya. I noticed a change in the children. They were happier. They were given milk also. They would give us 3 tins of milk per each child. So we would get 9 cans. They would give us weeks to feed them, and then we would call them and they would come and weigh the babies. They would come once a month. My experience was good because I could not manage on my own. Once I started getting the milk, I no longer had concerns. So as the nurses go into the villages, they build relationships as well, not only with the individuals in the households that they're coming to, but with the community members and the community leaders. This is what people will get when they come with an orphan. So they get formula, they get a thermos because there's no running water. The women will either get water from a borehole or sometimes collect it from a stream. Then they'll have to boil that water. And in order to make sure that they have clean water for the baby at all times, we have a thermos. And then we have sippy cups. They're easier to clean than a bottle. So these are cleaned with the boiled water. So this woman has collected her firewood, boiled her water, and pouring the water into her thermos. And I'd like to emphasize that there's no electricity in most of these homes, except for the ones that Ricapo is now helping. So these women are doing this in the, preparing formula in the dark in the night when the babies are hungry as well, washing hands, washing the sippy cup, pouring the water, cooling the milk, and feeding hungry babies. I love this picture here. Elisa's coming into another, home, and this is a different community to see this baby here. And she comes in and just sits down right with them, right where they are. It's so important that our nurses are visiting in the community. The nursing care is not just measuring and weighing and educating, but also assessing the complete environment. And here you can see, the thatch on this roof, and you can imagine in the cold, in the night, the air getting into this home. So the nurses can talk to the village leaders and try and mobilize people to help. These are things that the nurses do, or see if the baby's sleeping under a mosquito net. So all of that contributes to the well-being of these little ones. Some of the women that we visit, some of the babies are so remote that they can't be visited one by one. So they'll meet at a community health center on occasion. And we've also started rotation so that the women will meet at one household, and then the next month they'll meet at another household. And the nurses told me, I thought this was really lovely, that recently the women decided that the woman they were visiting was not doing a proper job in keeping things clean and organized and feeding the baby well. So they were the ones who stepped in to kind of educate and help her sort things out. So I thought that was great. We're seeing exactly where the water needs to be measured to make sure the formula is constituted correctly. A healthy baby on her back. And health education is always part of the visit as well. So in terms of the moms, it's estimated that in certain regions of sub-Saharan Africa, 1 in 5 deliveries results in severe maternal morbidity. So we talked about, the high maternal mortality rate, but that's really the tip of the iceberg. So almost 20% of births result in a woman who has some sort of lingering illness that's affecting their health and their ability to care for their children, which is just incredible. I have a quick quote from a woman here. When I gave birth to this child, I started getting sick. My stomach started swelling after I was discharged from the hospital. We went back to the hospital, and at that time, I couldn't even breastfeed. I didn't have any milk. So my sister took the baby and said she would be buying milk. The baby was 2 weeks old. I underwent 3 surgeries during my hospitalization, and each time the wound reopened. I stayed in the hospital for 3 months. When I was waiting for the wound to heal, it happened that the woman from Joyful Motherhood was visiting the bed next to mine, and they started asking for her name. They asked how she fed her baby, and she said she buys formula. They were taking the names down of babies whose mothers died or were lacking formula. They passed me and didn't know I also had a baby. I called and asked her what they were writing and told them I also have a baby. She asked me where my baby was, and I told her that it was with my sister. I called my sister to come the following day, and they started giving my baby formula. After we were discharged home, before even a week elapsed, they came. I saw a car come by. They asked me how I was feeling. I said much better, but they said I still look weak and gave me soya flour to make porridge. After I started eating, I felt better and stronger. Before that, I was wasted. I was looking pathetic. I thank God that they came here and that it was God who made me call out to them to come to my space. God should give them a long life. They helped both my baby and I. I could not have managed on my own. So this is one of the women who was discharged from our program. She had a severe infection and a total hysterectomy after a C-section. This is her third baby. And for her income generating project, she used the money to buy charcoal, which she sells to support, to supplement her income. So the other project that we have going, I mentioned, is a collaboration with Recapo, which is a local solar company, and they are putting light in some of the houses of our beneficiaries and also giving them phone charging stations. So women will use these to charge the phones of people in their community and get money for doing that. So this is a little video about Lydia and her story. She's one of the beneficiaries. Oops. Sorry about that. Let's try that again.
Most women in rural areas of Malawi find it hard to provide basic needs for a home. In efforts to ensure that their homes and children are taken care of, the Chimwemwe Mubeleki organization, in partnership with Recapo Solar Systems, is helping Malawian women by empowering them socially, economically, and financially through the provision of lactogen, porridge, solar phone charging business unit, and solar systems for lighting homes. One of the beneficiaries of this project, Lydia Malefula, a single mother of 6 children, of which 3 are triplets, whose names are Martin, Matthews, and Martha, has today received a solar home lighting system from Recapo Solar, with further plans to install solar phone charging business unit as an income generating stream to sustain and economically empower her home.
Chiyambi chake chinali chotani kuti mpezi kuti ino akupezani komanso ino mndini mmodzi mwa amene mukhala mukulandira nawo thandizo kwa Chimwemwe Mubeleki.
Ndabadisa anangawa nabadisa chama 12 ya usiku kuti acha mmawa ananga ali kumagetsi ndege nako ndachoka kumene ali makagona ku bedi ndimafa ndikaona ananga kumagetsi pamene amati AMHI tufune inuyo ndafuna ine aziti mwini ana atatu kuti ene ana atatu ndandipatsa makadi yawo ndiuzo ndigule phone kuti ndizilumikizana nawo azindithandiza anawa ndege nako ndadzagula phone ija nadzayimbira ante ndagula phone ndineyo jeni ana atatu kuno kunchinji ndazilo chabola pa 20 kunyumba kwanu ndiye pa 20 po panadzafika pano pa khomo panga kunthandiza kwake andandibwetsera flasiki ndi makapo motsala nankaka ndi zovala zana kenako mpana mtsandinga kama 36
pakali pano pa nyumba pano mmagwisa ntchito chanu kuunikira komanso ndi kuipa kwanji kwa zimene mmakhala mukugwisa ntchitozo zimene mmakhala mukumana nazo nawo mbuyo
padakale pano magwitsira ntchito kendulo ndiye kendulo oyo mwene makagula pa 120 mwina pa tsiku kuti matenga 240 kuti unikira usiku wonse uyu kuti kunja kuche ndiye tiona muna kendo ndamatilibe kapena muna magwitsi anthu aya pamenepo timakachitisa mafoni athu ndiye kana timagwitsa ntchito yani tumafoni tuchoti tiunikireko kumbali ya usiku ya ana kuipa kwa kendulo kulipo mwina matakuna kuyaka mwina zofunda zija tenthapo ndithu muna maneti tani tayatsapo ndithu ndiye kuti kulandira amene ngalandira zinthu zikuunikira zilandira bwino uphungu wabwino fanyana kuti 1 ana akhala moyera 2 anaso ndi angaso amene sikulu ngati 35 bila mtsogolo akangoti muna azitha kuwerenga nawo pakati pa usiku komanso kwa ine mwina ku business iyo inisamali fana ngasi muona kuti thandizo yani chana business ithandiza chifanyana kuti mavuto amene ala fonimo niwovutikira zedi ocheja ku anthu ngovutikira zifana ambiri amatha kudandaula wakuti achizisira foni yanga chita mwakuti ndiye munomwe ithandize fanyana kuti mwina nditha kusamalira mafoni ya ine yake kuti samale kuti ani akajawo azibwera kwatenga mafoni yawo pakhomo panga muyenerera.
So this has been incredible collaboration already. Goodness, how do I get out of here? We've seen some really nice, there we go. Some really nice results from this program, some things unexpected. So one woman was serving tea out of her house and charging people for that. And she said now she has 3 extra hours of business because she has a light in her house. So that was really great. And then Lawrence made this wonderful observation. Some of the kids were saying that the people were saying that their kids won't go to sleep without the light on now. They're so used to the light. And Lawrence was saying just by putting the light in their house, these kids are no longer going to accept a life where they don't have light. So they're light. So they're going to be striving to always make sure that they have light in their homes, which I thought was wonderful. So anyway, there is a lot I feel like that's coming out of our program. We're doing so much good in the communities, helping these women and babies. Some of those things are hard to quantify, but we are caring for 237 babies at the moment and 24 women. One of the things we can quantify, one of our outcomes, which I'm very proud of, is the survival rate for the infants in our program. So over 95% of the infants enrolled in our program survive. And you think about this, comparing it to the mortality rate. So that was between a 20 and 50% survival rate for these groups. So now we've brought that to over 95%. So what we've learned is that mother and child health are inextricably linked, and that the people who are making the changes, who are really motivated to improve their lives, who are doing the care, are our beneficiaries. We are the ones who are offering a little support. Targeted care is so important. So even though this is a very low resource environment, and it would be difficult or impossible to send nurses to every individual to provide such postpartum care, targeting these high-risk groups is making a significant impact. And the income generating projects are also critical for the improved economic stability of these homes. Just wanted to quickly show you this picture of our finances and our beneficiaries. You can see the yellow line over time going up with the number of babies and moms that we're caring for, as well as our income and our programs. So the last several years, our expenditures, or the program in Malawi has spent around $75,000. You can see that this last year was a huge outlier, and that really has to do with the fact that we received one large donation, which allowed us to put some money aside in reserve. So prior to this year, we have been operating really hand to mouth. We get the money and then we spend the money. So now we have a couple months in reserve. And then the orange here, we did not send as much money to Malawi this year because we had sent more in previous years. You can see in 2018, there was more income, and that was spent in Malawi this year. In terms of where we get our money and what we spend it on, so the bulk of the money that we receive is from individual donors. We would love to get more grants. That's always a question. We don't have any employees in the US at all, and everyone has a full-time job and children. So really a lot of it has to do with just time. If anyone has any ideas or suggestions on that, always welcome. And in Malawi, the biggest expense are the salaries. The key to our success is really the nursing care that's provided to the women and the children. So even though, many places will look at this as an administrative cost, this is really why this works, is because we have nurses. And then the second large cost is a formula. So many of these babies do not have access or insufficient access to milk. We're not replacing breast milk, but we're giving it to babies who really need it to survive. I recently had a incredible realization. I was listening to an interview with the founder of GiveWell. And for those of you who don't know about GiveWell, it is a nonprofit that's based in the US, which researches the work of other nonprofits and really analyzes where nonprofits are making a big difference and showing people where to give. So if you donate to these causes, your money is going to go the farthest. So their top causes, this individual was saying, the most efficient research-based nonprofits save lives for between $3,000 and $5,000. So I think, we commonly hear things, well, you can feed, 100 kids for, $5 a day or something like that. But they do a lot of rigorous research, and they were saying, really, this is the ballpark of what you can expect in the best nonprofits. So hearing this interview, I knew that we did better than that. And we have a very small budget. We're working on a small scale, but I knew our numbers were good. So I consulted an actuary, and he looked at everything. He looked at the data with me, the research from the region, and had me make a very conservative estimate. And so at the end of that, we came up with this figure that we save a life for less than $1,500. So we're doing a really good job. This is something that is most nonprofits aren't doing. So I feel really proud of that number, and really proud of our team in Malawi. So thank you so much for your time and your attention. We would love if you would be willing to partner with us, and you can donate on our website. Monthly recurring donations are very much appreciated. That way we have an idea of the money that's coming in.